Good morning.
Good morning.
I'm here with Judy Goodwin, who is the Senior Vice President for Strategic Initiatives at the Joslin Diabetes Center. Put in a little plug here, the world's most renowned institution for diabetes research. I think that's a fact,
Yes, it is.
not a claim.
Right.
And I think people often think of Joslin as a place, a building or a collection of buildings in Boston. But it really isn't just one place, it's actually many, and that's one of the initiatives you're responsible for. So talk a little bit about the affiliate program.
Yeah,
please.
I would love to. Thank you, Chris. We are more than a place. I think we think of ourselves as a purpose or an organization with a mission that transcends one geographic place. For about 27 years now, we've actually exported our mission and our model of care across the United States and in fact across the globe to replicate the care that we deliver in Boston in hospitals, medical centers, physician practices, long-term care centers, behavioral health centers. We say diabetes is everywhere, and so are we. And so going back 27 years, that was another physical place. But we look to complement that, especially in these days of healthcare reform, extending out into the community our care model and our training so that we don't just make an impact in a specialty center, but we make an impact in primary care and in the community as well.
Well, primary care is obviously a very important, maybe the most important battleground in diabetes. And I'd like to hear more about how you've been able to take the resources of a highly specialized institution and put the knowledge that's needed on the street where it needs to be.
Right, exactly. So you mentioned that the name of my division is Strategic Initiatives. As it happens, that's how we started, that we wanted to do new and different things in a lot of different communities. But I'd like to share that we've renamed the division, in keeping with much of the theme of this conference, Joslin Health Solutions, that we're really looking to work with like-minded partners wherever they may be to extend our mission to prevent, treat, and cure diabetes regardless of geography, regardless of setting. And so you're right, the Joslin in Boston is a highly specialized center where we treat diabetes in the adult and pediatric population, but also the complications of diabetes. Our group has recognized that outside of the Boston community, actually even in the Boston community, but more widely, most people with diabetes are treated by primary care physicians. So we've had a professional education program for many, many years that has actually targeted primary care physicians. We have over 130,000 such physicians who have been trained by us, who are in our database. And so as a natural progression or evolution of that training, we're now, again in these days of healthcare reform, working to deploy our care protocols, our pathways, and our standards of excellence around clinical outcomes to the primary care community.
That's wonderful. That's, I had no idea the number was that large. 130,000 is a lot of doctors.
Absolutely.
Well, tomorrow at the Joslin conference we're both speaking to each other at, you're going to be moderating a panel that talks about the use of mobile technology in sharing information and enlarging the circle of care. So it gives a sort of new twist on Joslin Everywhere. And obviously, as a mobile-based platform, we're very interested in what you have to say. So
yes.
Talk about what you expect to discuss tomorrow.
Well, there's lots of interesting programs and pilots and success stories across the U.S. and actually across the globe. As I mentioned, we have an international mission as well, a global mission, because most people with diabetes live outside of the U.S. And the cell phone is quite an ubiquitous device everywhere. And so we see that as a real opportunity. But it isn't the only opportunity. All of these virtual capabilities are complements to the face-to-face care that we've long delivered. And so what we're interested in doing is finding those success stories, conducting those pilots to create success stories so that we can have a vibrant and important platform that does complement the face-to-face personal care and extend the reach of clinicians and other healthcare providers, because as we've heard today, they're in short supply, and they're in short supply everywhere. So the Joslin has a number of technological capabilities. I mentioned our professional education efforts, and we've got a web-based platform that we use as a complement to live training. We have apps in the area. You might know that we're very active in culturally adapting our care model to different demographics. So for instance, we have a walk, an interactive walk that we've developed where we encourage those who are looking at, say, Asian cuisine to click and drag different foods into the walk and learn what are the carbs, what are the calories, and how do I create a healthy meal. And so, you know, these are episodic types of things that are important, but we're really looking for, again, partners, like-minded partners and collaborators so that we can build a more robust, comprehensive platform that is first and foremost patient-centered, that engages the patient, motivates the patient, and gives the patient the kind of information and encouragement to take really good care of themselves, because goes back to Dr. Joslin, that you know, diabetes is a 24/7 disease, and our best success comes when we can equip patients to be successful in taking care of themselves.
Yeah, you could almost say that the cell phone and diabetes were made for each other.
Absolutely, because of its ever-present nature, right?
And I think two thoughts come to mind. One is that in addition to providing useful information, such as the walk example, there's also a lot of motivation that is required to get through a day. Sometimes people with diabetes have great days, and sometimes they have not so great days. And
just like any of us.
But it often has nothing to do with what they're doing. It's the way their body reacts to many, many things that over which they may not have total control. So I'm curious to know how you see the mobile device, the cell phone in particular, as a motivational tool. How can we reinforce people by congratulating them or by patting them on the back if they are having a bad time?
Exactly. So you might know that we have a behavioral health section at the Joslin Clinic. And so for many years, we have been following some guiding principles about how to motivate and engage patients to take care of themselves and to stay connected, because it's hard. A lot of what we recommend are lifestyle changes, which none of us are all that keen on following, you know, every minute of every day. So just to give some examples, one of the things that the cell phone does is it gives you some immediate feedback. So if you send us some biometric data, say around a glucose reading, and we can immediately come back to you, or in a reasonable amount of time, not in a day, and say, Chris, you're doing a great job, keep it up. Or, Chris, and this would be against the backdrop of some information we know about you, you know, maybe we should talk, and maybe we'll have a health coach intervention to help you get back on track. A guiding principle throughout is it's a tough disease, and we're all busy, and we're all under lots of stress and pressures. So it isn't a blame game. We want to help our patients establish realistic goals that they can meet, and that they can celebrate that success that obviously will translate into better health.
And the more the patient shares with you, the more you can do to help them, right?
Absolutely, absolutely.
On the other side of the coin, this ability to interact, to dispense information and to receive feedback is obviously a great tool, but I wonder how it fits into the traditional workday model in a healthcare organization. I mean, for instance, there are only so many hours in the day. There are only so many things a specialist, no matter how well-intentioned, can do. So I'd like to know how you at Joslin have thought about modifying the work structure to make it possible for your specialists to spend more time perhaps responding to virtual as opposed to real patients?
That's an excellent question, and we do spend a lot of time thinking about that. And in the panel discussion that we just heard, there were some references to where lots of folks are going in this direction, and we are as well. So it really boils down to the highest and best use of the resource. And so where can endocrinologists, as part of the team, make the biggest impact as we increasingly think about population health and moving the dial? And so, of course, there are going to be difficult cases that require specialty intervention. But more broadly, we're looking at the models where endocrinologists can empower primary care physicians, and in turn the community, and in turn embed all of this expertise in global devices or technological devices that really help to extend the reach. And you're right, it's a different model than in the fee-for-service world where physicians found themselves seeing patient after patient. Now we need to think about a day that includes seeing difficult patients, that includes some training and outreach, and that includes some virtual kinds of interventions in order to extend our impact.
I think the fee-for-service, the financial part of this is obviously very important. You have to reward primary care physicians, or specialists for that matter, for spending their time doing the things you described. At the end of the day, it's all really does come down to the bottom line. Otherwise, we can't continue to do what we do, whether it's Insulin Nation as a website or Joslin as a
right. That is the world we live in.
And so, at the end of the day, it is, in some part about the money.
Yes.
I wonder also, how do you measure success? For instance, you have 46 affiliates. Are you looking to add more affiliates? And if you were, over the next 5 years, what would you think the target would be? In your internal programs, how do you set benchmarks so that you can say, there may not be any money against this, but here's what we accomplished?
Really important question. And so when we started our affiliate program many years ago, we started it with a strategy that said, well, we want to go slow and we want to start with institutions that look like us, academic institutions. But very quickly we realized that, again, diabetes is everywhere, and why shouldn't we be in communities and in community hospitals? And so we began to broaden our reach. And I don't know that it's so much about having a specific number in mind. I think we're still at the point where, even though we have 46 centers, and we've got over 100 providers, over 100 educators in our network outside of Boston, when you think about the fact that there are over 25 million people with diabetes and we're treating a small fraction of that, we need to think about ways to make a bigger impact. So yes, absolutely, we want to grow that physical network. We want to continue to do it in the healthcare delivery space as we've traditionally known it. That's evolving into accountable care, population-based organizations. And so a key element of our strategy is to find like-minded partners who really want to make a difference in a region. So not just to have a specialty center, but to have those concentric circles of primary care and community care. It's another emphasis that our Joslin Health Solutions division has had over the years, is to get out into the community and identify people at risk and get them into care.
And one of the parts of the panel discussion that was going on just before you and I started to talk was focusing on the importance of the county health department. And I don't know how many counties there are in the United States, but I know there are thousands. But that's a sort of hidden but very important resource that often interacts with people who other parts of the system just don't reach, whether because they're not insured or they're uncomfortable,
Exactly.
with, because of white coat syndrome, whatever.
Exactly. And so, not that it's exactly county government, but one of our key successful programs has been working with extension agents in rural areas of this country through a program we call On the Road. And in fact, we were a recipient of one of the early CMMI innovation grants. We had over 10 years worth of data working in underserved communities where people weren't in traditional healthcare settings but were at risk, screening them, providing some information about the importance of knowing about glycemic control and blood pressure and cholesterol, and encouraging them to get care if they were identified to be at risk. And based upon work we'd done in 5 major communities in the country, Western Pennsylvania, Hawaii, believe it or not, on the Big Island, that's very underserved, New Mexico, West Virginia, and Washington State. Again, having the data and showing that by doing programs like this, we can reduce A1C and reduce blood pressure. We were awarded this grant to scale it in different settings. And so that's a key part of our mission.
Now, we're well aware of the fact that Hawaii is not paradise when it comes to diabetes. Very, very high incidence.
Right.
Due to the Pacific Islanders.
Right. Now, you mentioned the panel I'm going to moderate tomorrow, and there's a diverse group on that panel. And so as we think about how to make an impact, and kind of in keeping with your question about how do we expand, what do we think about making an impact, we're looking at settings and opportunities with partners that we haven't in the past. So it isn't just health systems, but it's employers and it's payers, and it's ways to embed our programs, whether they're branded and whether it includes every element of what we do, or whether it includes those special elements that will help them achieve their goals and have an impact on people with diabetes. So we call some of that our Joslin Inside strategy, that we can help power other organizations who are trying to move the dial.
It seems to me that you might succeed greatly with that strategy, because in some ways the not invented here syndrome could be an obstacle to adoption of your protocols by another academic, particularly medical institution.
And there we're all about collaborating. We put our ego aside, and it's all about collaborating. I did want to mention one other thing. You had asked me earlier in our affiliate network, what do we do and how do we deploy our mission? Obviously, we do embed our care pathways, our care protocols, our education curriculum, but we have to inspect what we expect. And so we, in our branded programs, have what we call, a relentless oversight program to be sure that patients who are treated outside of Boston will get the same care that they would at any Joslin center. And so we thought a lot about how we measure success patient by patient, physician by physician. And we wanted to go beyond a report card that said, here's the level of glycemic control measured by the A1C, this doctor, that doctor, but we wanted to give physicians, practices, actionable data. So some of our very creative, passionate, and dedicated physicians at the Joslin came up with a proprietary tool that we call the Joslin Clinical Analytic Tool, that based upon gender, duration of the disease, medication, therapies, we can help physicians who may see that they have a patient out of range quickly see how to advance therapies, where they may need a little extra training, where we can help. We heard about office systems sometimes need to be revamped. We're experts in that area, helping people to really organize themselves and their practices in ways to be optimally successful for patients.
Well, it all sounds wonderful. Joslin, as we both know, is a world-renowned institution for a good reason. And thank you very much for sharing just a little bit of what you guys do every day with us. We'll look forward to more in the future.
Well, my pleasure. Happy to do it.
Thank you.